Yeah, thanks a lot, Nikhil, and also special thanks to Dr. Namrata Sharma for having me as part of this session and to Ajanta Pharma for this wonderful forum. Since this is the last talk, I'm not going to take too much time, but I think the three aspects of what I would like to cover in this talk is why we would do endothelial keratoplasty, when do you think of endothelial keratoplasty, and then finally, how do you do it? So, when we talk about corneal transplantation, really going back in time, there have been several evolutions of techniques of corneal transplants, from initially using keratoprosthesis, animal corneas, to probably the current methods of corneal transplantation and also the techniques that have been popularized by various visionaries to the current endothelial keratoplasty that has become mainstream for patients with endothelial disease. Now, the reason why this is very important for us is because the amount of blindness that we have as a country is disproportionately large compared to the resources that we have, including the number of corneas that we have as well. And the number of corneas that we have available is probably better off than some developing countries in the world, but we still have a lot of catching up to do. The number of cornea patients that we see with different disorders every year is quite significant, and we see more than 100,000 patients with corneal disorders every year. And the number of transplants that we do every year also seems to be rising. And this actually is a compendium of about 41,000 transplants that have been done in the last 35 years. But what is interesting is the fact that when you divide these transplants, but the type of indication for the transplants, we find that almost all indications seem to be showing a downtrend. That is, lesser number of transplants are happening in the recent few years, even notwithstanding COVID-2. But endothelial disorders and infections seem to be on the upsurge, with the number of patients who are undergoing transplants for these diseases seeming to go up every year. And in fact, when we looked at the total number of transplants that we've done in the hospital, we found that endothelial keratoplasty was overall, historically, the third most common type of transplants that have been performed in LVPEI. And last year, endothelial keratoplasty was the most frequent type of transplant that was performed, even more than transplants for infection or full thickness corneal transplants. Now, the two main kinds of endothelial keratoplasty that are prevalent or available right now are DSEC and DMEC. Both four-letter words, but the difference here is the fact that in DSEC you are adding tissue with stroma, endothelium and Descemet's membrane behind the cornea. In DMEC you're only adding the Descemet's membrane and endothelium behind the cornea. So which is better between these two? In fact, most surgeons will start with DSEC because it is a very straightforward procedure, very few complications in surgery, and also not many skills that are required to start doing DSEC surgery, just require the same skills as you have in cataract surgery. So most people can transition to doing DMEC quite easily. And that is the reason why this is probably the first surgical procedure most corneal surgeons will start doing. But then there are several advantages of DMEC over DSEC. And I'll just go through those advantages quickly. As you see in the picture in the OCT, DSEC can result in significant thickening or addition of tissue to the cornea, and thus anatomically it is not natural. Whereas DMEC is anatomically natural because what you're removing is Descemet's and endothelium, and you're replacing Descemet's and endothelium, so you're not really changing the thickness of the cornea. But probably the most important reason is DMEC seems to have about an 8 times lesser risk of rejection compared to DSEC surgery. And this is the reason why now we are even trying to do DMEC post-corneal transplants, because it seems to increase the longevity of these grafts as well. There are several other indications and improvements because the visual quality after DMEC is as good as an unoperated eye, and you can have patients where 20/20 is the norm, and there are patients who achieve 20/16 vision as well, which is a little unusual in patients following DSEC surgery. The intraocular lens power, if you're doing a cataract surgery along with this surgery, is also much more predictable because in DSEC, the average amount of hyperopic shift is about 1.5 diopters, but in DMEC it is only about 0.5 diopters. Visual recovery also is much faster after DMEC. This is a picture preoperatively of a patient with corneal edema. This is on day 1 and this is on day 3. I'm not saying that all patients tend to recover like this, but then the opportunity of these patients to recover somewhat similar to how your cataract patients recover is a completely new area that we see in the area of corneal transplants. Now, refractive predictability also is better with DMEC because in DSEC surgery, the smallest incision size that you can have to safely insert a tissue is about 4 millimeters, and that can actually lead to not irregular, but unpredictable astigmatism after surgery. Whereas in DMEC, you can inject the DMEC graft through a 2.2 millimeter incision as well, making the surgery astigmatically neutral from the perspective of what you induce during surgery. So there are some surgical technique differences here, but obviously we're not going to all of those right now. But it seems that clearly DMEC is potentially a better surgery than DSEC at this point of time, mainly from the point of view of visual acuity. And there are several reasons why DMEC is better than DSEC, including a lesser risk of rejection. So the next question is, when do you plan to do an endothelial keratoplasty? Several patients might have corneal edema that is irreversible after cataract surgery, and when visual acuity does not improve for at least 3 months after cataract surgery, or the patient develops symptoms where he starts to have watering and pricking sensation because of the bullae, all of these are indications to do endothelial keratoplasty. And in some cases, when the IOL is unstable, in cases after cataract surgery like an AC IOL, and you find that this is contributing to endothelial damage, this also is an indication to endothelial keratoplasty. There also are indications of endothelial keratoplasty or combined surgeries in patients with very early corneal edema or no corneal edema, where you have a cataract and you're planning to do cataract surgery. In these cases, usually the OCT or the pentacam is a very useful method to determine whether you should do cataract surgery alone or whether you should combine cataract surgery with DMEC as well. Traditional teaching used to say that specular microscopy is useful, but it's not as useful, so it's preferable to do a pentacam or an OCT to make that determination of combining surgeries if required. Now, the other important aspect of DMEC is the steps. Again, we're not going to go into the steps of DMEC surgery. I'm just going to show you an animation of how it is done and then maybe a quick surgical video of how you'll unfold the graft. So DMEC surgery basically has 4 components. Number 1, you need to create incisions to take off the host desmase membrane, and because this is done mostly in patients who have abnormal desmase and endothelium, it's important to remove this, otherwise the cause of glare like guttae will remain after surgery as well. So there are many methods to do this. Here what we're showing in the animation is putting an air bubble inside the eye and then using a reverse Sinski to incise or cut out the margins of the desmase membrane. And once you do that, then using a stripper or a scorer to remove the desmase membrane from the host in one go. This is a relatively simple and straightforward step of surgery, and usually in Fuchs dystrophy, where the corneal desmase membrane is thicker than normal, is usually much easier in patients than in patients who do not have Fuchs dystrophy. Now, once the desmase membrane of the host is removed, then the donor is prepared. We are not going to show you those videos right here, but the donor is prepared and then put in a petri dish of fluid, and this donor is loaded into a glass tube or injector and then injected into the anterior chamber, and then using a number of maneuvers, this is then unfolded to ensure that it is the right side up, and this is ensured by marking the donor as well so that you can identify what is the correct orientation. Here you see what we are showing in the animation is injecting an air bubble to open up the donor, and once the donor is completely opened up, you can see that it has a mark, a P mark that tells you that that's the correct orientation. An air bubble is used to stick the donor to the cornea. So we're happy to announce that now in LVPEI we also have pre-stripped desmase membrane, and surgeons can avail this facility where they can order the DMEC roll directly from the eye bank right now, which is prepared by eye bank technicians. And once the roll goes inside the eye, you inject it inside the eye like I'm showing you right here. And once it's completely inside the eye, you use a number of maneuvers to open up the graft and also ensure that it is stuck to the cornea. And you can move it around and manipulate it so that it goes into the correct orientation. And once one flange of the graft opens up, it's a question of ensuring that the rest of it opens in the correct orientation, and then you stick the graft and ensure that it is well attached. So the biggest advantage of endothelial keratoplasty over traditional techniques of penetrating keratoplasty is the fact that they result in a significant improvement in vision post-operatively, at least 10% better than traditional penetrating keratoplasty. And that is the reason why endothelial keratoplasty probably is going to replace or already has replaced PK for patients who have endothelial disorders. But what should we look forward to? In a few years' time, it seems as if the future is not about surgical technique. In fact, just about last month, there is a biotech company called Orion Biotech, which has got approval for a new drug application to inject endothelial cells into the anterior chamber in patients with Fuchs. This is a company that at least Shigeru Kinoshita is involved in the running of the company. And potentially in the future, one human donor cornea will be able to supply enough number of endothelial cells to be able to do surgery or do these cell injections into approximately 100 recipients in the future, potentially removing the shortage that we are having for donor corneas at this point of time. And this probably will eliminate the need to learn skills like DSEC and DMEC in the future. So this talk in the future will become irrelevant. Thank you very much.
Thanks, Pravin. That was a wonderful talk.